Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation educational series. This evening, we're going to be talking about the puzzle of itch in elderly adults, putting the pieces together. Our moderator this evening is Dr. Leon Kircik, who's the president of the International Dermatology Education Foundation, clinical professor of dermatology at the Icahn School of Medicine at Mount Sinai in New York, adjunct clinical professor of dermatology at the Indiana University School of Medicine in Indianapolis, and medical director of physician skincare, derm research, and skin sciences. Our presenter this evening is Dr. Danielle Butler, who's associate professor, division of dermatology, assistant dean of students affairs, and director at inflammatory and aging skin research program at the University of Arizona College of Medicine in Tucson, Arizona. We'd like to thank our supporters, Sanofi Regeneron, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the information will be displayed. If you're having technical issues, please submit your questions in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser and also will be sent to you 1 to 2 days later. We'd greatly appreciate it if you could fill it in and send it back to us. And within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. Again, if you want to submit any questions for our faculty, please submit your questions in the question chat pane on the right-hand side of your screen. And now, without further ado, I will pass the floor virtually to Dr. Kircik.
Thank you, Roxanne, and good evening, everyone. Welcome to another series of International Dermatology Education Foundation educational series. So before we go any further today, I'm going to tell you a little bit about IDEF, and we are a nonprofit organization with principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. Since the pandemic, we are serving our audience all over the world, not only in US, but also in Canada, in South America, in Europe, Southeast Asia, Japan, and Australia. And as you can see from some of our previous programs here, we have a wide range of audience. And please stay up to date with us at our, not only at our website, idefeducationseries.com, but also at Instagram and LinkedIn, as well as Facebook. Tonight, we have a very, very special program from a very special guest. First of all, our speaker is Dr. Danielle Butler, one of the young upcoming stars in dermatology. He is already an associate professor at Division of Dermatology, and he is the assistant dean of student affairs at University of Arizona in Tucson. But most importantly, we have a great subject tonight. You know, itch is an unknown origin of itch. It's a big problem. It's even a bigger problem in our elderly population that we always struggle with. You know, we say, it's a xerosis, it's dry skin, use some moisturizer. Sometimes we do some labs to find out where it's coming from, but we really have very hard time to treat and how to diagnose those patients. Now, as we're learning more and more about the Th2 pathway and how that itch plays a role in the Th2 pathway in elderly adults. So, Dr. Butler, come on up and take it from here and tell us all about it.
Well, thank you so much for that wonderful introduction, and I truly couldn't be more excited for this this opportunity. This one hits close to home. I was just mentioning to Leon and Roxanne as we were getting started. This topic is literally the reason why I became a dermatologist. I wanted to be a geriatrician when I was in medical school, and I would go to geriatrics clinic, and I saw that many of the patients, despite having what we perceive as very serious comorbidities, were actually concerned with what was going on in their skin. What's this lesion? Why am I itching? What's going on here? And it started to click for me as this could be a really fun area of curiosity. So that was about 15 years ago. I was trying to put the pieces together then, and I still am now. And let's share some of that. So let's dive into it. So this is the puzzle of itch in elderly adults. and we're still learning to put the pieces together despite how common this is, but it's certainly a fun, interesting place for us to dive into. Let me keep going here. So of course, this program is non-promotional, but it is sponsored by Sanofi and Regeneron. I am compensated for this talk, and I did work with Sanofi and Regeneron to create the content of this lecture. Sorry, going the wrong direction. Here are my disclosures. And then let's get into the learning objectives for today. So I'm going to read these because I want to be deliberate. These are very important for the entirety of this topic. We're going to cover a lot. So the first thing is to recognize the cumulative burden of chronic pruritus in older adults and its compounding effects on existing medical challenges. So this is huge for us all. We know this exists, and this is something that I don't think dermatologists have quite jumped into as thoroughly as I hope we can in the future. Number two is to understand the unique pathophysiological changes of aging skin that drive pruritus, including immunosenescence, neural hypersensitivity, and barrier dysfunction. These are the pieces of the puzzle that are new for me within the last 10 to 15 years. These are the things that we've been able to start putting together, and it's really transformed how I communicate with patients and how I treat patients. Number three is we're going to recognize the role of type 2 inflammation in driving pruritus in conditions such as CPUO, which is chronic pruritus of unknown origin, AD, PN, and BP. And then the last one is we'll apply the knowledge of the neuroimmune dysregulation to improve our clinical decision-making and patient outcomes. Because at the end of the day, this is all to get our knowledge more comprehensive so we can ultimately take that into our patients' rooms and help their lives. This is what's really important to me. There are so many older adults out there suffering, and we in dermatology can be a huge part of making their life even a little bit better, in some cases substantially better. So first we're going to hit a polling question. So I want you guys, I'm not going to tell you the answer, but I do want you guys to jump in and answer this question. In which common pruritic skin disease of the elderly does type 2 inflammation play a central role? Now, this is a tough one. We're not going to go over the answers, but which one plays a central role? Key point is central. I'll give you a second there. These are all common conditions in older adults, but the central part is the most important. And it's interesting because not all of these, as of recent, were even understood as diseases specifically of older adults. All right, I love it. We have a mix there. So we'll see if you all were right or wrong. Let me grab control here again and we'll move forward. So here we go, unmasking the itch in older adults. So first of all, let's talk about something that we all know. There is a growing population, and as we were working on the slides, I sort of cringed at the idea of a crisis. Now, I really don't think this is a crisis, but I wanted to leave this in because it's more provocative and it's more fun to hear. So this is by no means a crisis. You know, older adults are certainly nothing to be worried about, but it just is a new challenge for us. You know, this is a growing population, the adults over 65, and I just want to make sure everyone knows 65 is not old. You could be 65 and you know, live the life of a 40-year-old. You can also be 65 and be very old. So it's just the cutoff that our medical system has, mostly because that's the Medicare cutoff. But long story short is this population is growing. So 1 in 6 already, that's actually grown even since 2020. And of course, this population is growing faster than many others. This is a phenomenon that we actually see internationally. You know, you see some countries such as Japan, where you're seeing almost half the population over the age of 65. So this is something in Europe, it's very similar. It's almost 1 in 4, and projections show 1 in 3 very shortly. So long story short, this is a population that's growing. And again, not a crisis, but certainly something that's going to present in our clinics. And then when we take that focus to look at itch, you see that itch is a disease that's associated with age. So here's a chart that shows the presentation of itch in each age demographic population for males and females. And not surprisingly to anyone who's seeing patients in clinic, as someone gets older, they're more likely to present with a chief concern of itch. So this is true, as you see, for genders. And then there are several studies that substantiate this across demographic and ethnic groups as well. So long story short, age and itch are intimately connected, and 1 in 4 older adults experience chronic itch. So if you're not a geriatric dermatologist, spoiler alert, you already are, because you're going to be seeing a lot of these patients if you're in a gen derm clinic. So now let's talk about the burden. And while there's a lot going on this slide, I think this is that type of slide that resonates with us, because this is what we see every day. And when we think about itch, I want to show you guys that the white chart on the squared chart on the side, and just highlight the main points there, where you're seeing that chronic itch is associated with many different types of burdens. It's not just that they have itch and that's it. The itch has this insidious way of getting into one's life. So number one is there's the physical burden. So if somebody is older and they're already having challenges with their physical environment, they're not as robust as they used to, itch is going to take away some of that margin. It's going to take away some of the sleep that you need to be able to carry that margin. It's going to impair your physical activities. It can even lead to secondary infections, and all of these are going to substantiate that physical burden. Number two is that there's a psychological burden. I mean, imagine that time that you were itchy and it was horrific. You say you got a bug bite or you had allergic contact dermatitis. Imagine that level of itch, but extended over weeks, months, and even years. And this clinically has shown to lead to depression, anxiety, social isolation. That's probably something we've all seen in clinic. And then what I love that's included here is the actual practical side of things, which is it's not just the physical limitations, the psychological burden, but it also impairs our ability to engage in the healthcare system. And not only can it lead to hospitalizations, or can it make comorbidities worse, can it increase medications leading to polypharmacy, but really what it does is it makes these older adults patients even more so than they already are. And what I mean by that is our whole goal with any patient, but particularly with older adults, is to keep them away from hospitals, to keep them away from clinics, let them live their lives doing the things that they love doing. But with chronic itch, they're going to be engaging in the healthcare system. And all of this leads to impaired quality of life. This isn't surprising to anybody, but it impairs their ability to operate in this world. And that's the tragic piece of this. And then I'll highlight that one small piece at the bottom of the red circle or orange circle that says many patients report they would rather live a shorter life free of symptoms than a longer life with pruritus. And that's one that can just sit with you for a second. I don't think that often comes up in a room because it's probably exceedingly vulnerable, but it does communicate how impairing the quality of life impacts are for these older adults with chronic itch. And then we all know how impairing this is. We all know how challenging this is, but why are we behind it? Why is it under-recognized? And there's a lot of pieces to this. So number one I'll highlight is that there's multiple etiologies. And I will tell you that anytime there's multiple etiologies in one symptom, medicine really struggles. Because when you have an itchy patient and there's nothing really to see on their skin, but there are numerous different things that it could be, it's a little disarming for us as dermatologists who are by nature visual morphologists. That's our superpower, is we look at the skin and we're able to make a decision. And something I talk to my residents all the time about is when we have a patient who comes in and they're erythrodermic head to toe and they're 10 out of 10 itchy, that's someone that we are very actionable with. But that same patient, 10 out of 10 itchy, but they don't have much on their skin, we are less active about it. Despite the fact that both of these patients are very, very impaired by their skin disease, there's one that we're activated by and the other that we generally shrug our shoulders at. And this is one of the reasons why. And then underlying to that is this concept of diagnostic challenge. So we have listed many of the diagnostic challenges there, and I'll highlight a few of them. So the lack of a clear diagnostic marker is a major one. So, you know, every first-year derm resident can order their itch-no-rash differential, and oftentimes that comes back without any specific finding that can tell us exactly why someone's itching. Or it will come back with something that doesn't give us the whole story, like minor changes in kidney function, maybe a little bump in LFTs and ALK-Phos, but none of those give us our exact answer, and that leaves us somewhat disarmed. Of course, these conditions can mimic each other. Of course, there's a wide range of presentations, which is another one that has hampered our ability to not only define this, but build consensus to study it. And all of that packaged together has resulted in delayed diagnosis, prolonged suffering, and missed opportunities for intervention. And I will also say that it's led to a real challenge in our field where that lack of consensus has meant that we can't really study moving forward. You may have learned in residency or in practice about 10 different names for itch in older adults. And what that's done is that we can't build one single etiology that can ultimately bolster our ability to study this in Arizona and New York or Montreal or Paris. Ultimately, we've struggled because of this lack of consensus, and that's why this under-recognition has led to frank under-treatment for these patients. But now we are putting those puzzle pieces together, and I think this is the key slide of this entire presentation. Now we're starting to understand the pathophysiology of aging and how it impacts the pathophysiologic systems involved in itch. You know, credit to the itch gurus of the world. They've put together an incredible and novel disease schematic for itch. But if you take a one step to the side, you'll see that aging impacts each one of those systems. And when I'm talking about those systems, I'm talking about these three. I'm talking about barrier dysfunction, neuropathic changes or damage, and then the immune system or immune decline. These are the three systems that impact itch for any patient, but particularly in older adults, the aging physiology impacts each one of these, and it puts together a schematic to help us understand exactly what's going on. So if you think back to that slide where I talked about there's a mix of etiologies, it's a messy nomenclature, we haven't been able to build consensus. Here is our consensus. Yes, it's not a single name, but we're thinking of it from a pathophysiologic standpoint. We're putting those puzzle pieces together so we can ultimately communicate to this to the patients and then help build treatment algorithms based on this consensus affected, consensus affected systems. So let's go into this. Here is the science behind the scratch for age-related itch. So first and foremost, let's take a look at that first system there, the epidermal barrier dysfunction. So this is something that's been long known, and if you've watched any ad about skincare products, you're going to hear that the barrier is damaged or the barrier is dysfunctional as we age. That's true, but there's a lot more to it. So a couple of the things that I think are really important to this discussion is that the barrier gets damaged both from extrinsic and intrinsic elements. What I mean by that is your outside barrier is being assaulted constantly by everything that you're coming across. Cold weather, harsh detergents, warm water, these are things that we talk about all the time. But in addition to those things, you also have intrinsic aging changes, things like decreased sebaceous and sweat gland activity that decreases the intrinsic fatty acids and moisture of the skin. You also see really important pH changes where you see an increase in the pH. It says decrease in pH acidity, and that's true. It becomes more basic. So the pH increases as we age, which changes the microbiome. And part and parcel to that is the decreasing estrogen levels, particularly in our female patients. So all of these aspects lead to a barrier that's constantly challenged and having to respond all the time. And here's the real pearl. The pearl is that our aging skin barrier is actually not bad. And when you just look at it compared to a younger cohort, it's almost the exact same if you're looking at them in the exact same environment. Where the aging barrier really is challenged and has marked differences to younger patients is when it's damaged, how it responds. So you'll see, and the estimate's about half as quickly, that when a barrier is damaged, older patients have about 2 times the time to get to their normal level of barrier function as compared to their cohort. So it really is, it's like exercise. When we were younger, we could go out and run as much as we wanted and it never hurt. But as we age, it gets a lot harder to recover as quickly. And that's the same thing with our barrier because of these exact things. And then if you're not recovering and that barrier is not as functional, you know what's going to happen. You have increased susceptibility to allergen, irritants, infection, pH changes. You're going to have more dryness regularly. And then, of course, you're going to have more damage. So it's going to propagate. So long story short is these intrinsic and extrinsic factors are constantly challenging the barrier, and the barrier is constantly working to repair itself, and it's much slower than it was when we were younger. So that's the story behind the barrier. Now, how about the neuropathic damage? So there's a lot that goes on with the nervous system in the skin. And I will say this is the frontier that we probably know the least about. You know, I credit a lot of the scientists in derm now that are starting to look at this neuroimmune cascade. But the nerves are kind of what I think of as the next frontier for us to understand better. And there are some truisms, things like decreased nerve fibers, aberrant nerve activity. But if you look at it from a very basic level, there are certain things along someone's lifespan that can damage nerves. And each time those nerves get damaged, you can see an increase in aberrance of activity. Some of the most common ones are infections like herpes zoster, systemic conditions like diabetes, radiculopathy that can hit both the lumbar and the cervical spine. And then, of course, if you've had any central or peripheral necrosis from a stroke or something like that, you're going to have nerve damage. But I don't want this to be misconstrued. You're not going to just have neuropathic itch or elements of neuropathic itch because of these really profound neuropathic changes. One thing that's not discussed on this slide that's really important is this concept called neuroplasticity, which is another concept of the aging nervous system, which is that as we age, our nerves get better and better at what they're supposed to be doing or what they've been trained to do. I sort of think of neuroplasticity as a stubbornness or a bullheadedness of the nerve. So imagine this. If someone has had an itchy skin condition for a really long time or a disrupted barrier for a really long time, those nerves have been sending a signal for a really long time to itch, 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 itch. And if they've been trained to do that for months, years, decades, they're going to continue to do it. And that concept of neuroplasticity, that stubbornness, is going to continue to propagate that behavior. So long story short here is you are seeing a persistence of aberrant nerve activity, whether that's from pathology itself or just from chronicity of other systems involving the nerves that causes this cascade. And then the one that I think is the most interesting, and again, a little bit back to my story of the first piece of the puzzle that I thought was fascinating, was the immune decline as we age. And when I was in medical school, aging and the immune system, the correlate was this concept of immunosenescence, which I learned was a decline in the immune system, a decrease in the immune system. And I was shocked when I got into dermatology and I saw that the aging immune system was actually very active. It wasn't declining. It certainly wasn't less. If anything, there was like more immunologic signals. So I became fascinated with that. And lo and behold, as you know, aging immunology has evolved, we've discovered that the aging immune system is not actually declining. It's just acting more aberrant. It's acting in ways that it's not supposed to. It's still very functional, still doing the most important things, but it has these aberrant activities that perhaps it wouldn't have done 20, 30, 40 years ago. And I want to introduce you to two main concepts here. Number one is this concept called inflammaging. So it's a clever wording, but really what it is this idea of these pro-inflammatory cytokines that are circulating in the body, and they increase as we age. And there's not one single cytokine that's increasing as we age, and there's not one single system that's involved, but it's this pro-inflammatory state that's related to many different things. Visceral fat, autophagy, DNA damage, oxidative stress, immunosenescence is part of it. All of these systems are contributing to this pro-inflammatory state, and this low-grade inflammation can have an impact on many different systems. It can impact the kidneys, it can impact the central nervous system, and then in the skin, it can absolutely have its effect both visually and symptomatically on the skin with things like our favorite symptom, itch. So this concept is so important because what it starts to do is it puts a piece of the puzzle back to something that makes sense to us. We're seeing these people with these non-characteristic presentations of over-immune activity. So it doesn't make sense that it's just a decline in the immune system, but actually what we're seeing is in some areas of the innate immune system, we're seeing a decrease in cell migration. We're seeing these senescent cells that are secreting pro-inflammatory cytokines. We're seeing an increase in Th2 immunity. We're seeing a shift in immunity in certain cases. Long story short, this is not a monolith. Not every patient has the exact same immunosenescent profile. Every patient is a little bit different. But the takeaway from this is that an aging or an immunosenescent immune system is not just this gradual decline. In some ways, it's a decline in function, but an increase in overall activity. So there's nuance to the answer there, and that's so important because for a long time, the teaching about immunosenescence was graded towards just this overall decline, and I know that's not true. And a key concept here that I hit on is this concept of Th2 immunity. And again, there's nuance to this, but in immunosenescence, or this concept of immunosenescence, you often do see this secretory profile where these senescent cells that have just decided to say, hey, we're not going to behave normally anymore, and we're just going to secrete our cytokines as we want in this sleepy version of our old cells. We do see often this skew towards the Th2 profile, which is an important piece to this discussion of itching, because we know that Th2 immune system can be very itchy, hence why we're seeing so much itch in this population. So as you would expect, that's our next discussion point, which is the role of the Th2 immune system across a range of these pruritic skin conditions, specifically in older adults. So this may be something that you're really familiar with, but we thought it was really important to give you a historical reference to this. So let's look at the Th2 immune system. Like, let's take this puzzle piece and go way, way, way back. Let's do a really far track to understand why this Th2 immune system may be not acting like we want it to. So what that Th2 immune system is actually there for is to create these cells and these immunoglobulins that are going to fight helminths and parasites and worms that perhaps in our world we don't see as much of. And so a great example of this is how we initially get class switching to IgE. So long story short, if you look at the initial presentation of, say, a worm into our immune system, you would have the dendritic cells that are going to present to CD4 cells that are going to lead to the differentiation and isotype switching for developing these anti-parasite IgE antibodies. And If that's happening appropriately, great. Those anti-parasitic, anti-helminth IgE antibodies are going to be really effective against that parasite. But if you don't actually have that parasite around, what's going to happen is you're just going to produce way too much IgE, and that's going to lead to allergen sensitization. That may be something we see. How about the role of some other type 2 cells like eosinophils and basophils? So interestingly enough, eosinophils and basophils are chocked full of these anti-worm cytokines that are supposed to destroy those are supposed to destroy the worm if they degranulate. So what happens if those basophils and those mast cells actually degranulate inappropriately? Well, unfortunately, they're going to cause some tissue damage, and they're going to actually impact that barrier function. How about this itch scratch cycle that we've talked about for so long? One thing that drives me crazy is oftentimes, lay folks actually think of itching as just this element of self-control. How many patients have come in, they're itching, and they're like, yeah, everybody tells me to just stop. Well, the truth is these are built-in neural networks that are there to actually help us remove worms from our skin, remove parasites from our skin. But when that pathophysiologic mechanism that's telling us to do that neural network is aberrant and not responding appropriately because the Th2 immune system is telling it to do the wrong thing, then we're just creating wounds and we're actually disrupting our barrier perpetually. And then the last thing, and we'll just bring in the fibroblasts, another area that's growing, that our understanding is growing rapidly, is what happens when the fibroblasts that are there to repair this damaged skin, where supposedly the worm had just been and was supposed to get thrown out of. But if that was never there, then you just have perpetual activity of the fibroblasts that are repairing skin that was never supposed to be damaged. And ultimately what you're getting is hyperplasia and fibrosis, all of which are things that we see in clinic today. Allergen sensitization, repeated tissue damage, barrier dysfunction, hyperplasia and fibrosis of lichen simplex chronicus and prurigo nodularis. So long story short, you can see how the Th2 or the type 2 immune system was well-meaning when it was created, but boy, oh boy, does it make sense when it becomes aberrant for what we see in clinic. So let's talk a little bit about type 2 inflammation across all its diseases. And as we look at the type 2 inflammation cascade, you can see that certainly dermatology is the place to be. Bullous pemphigoid, CPUO, AD, PN, CSU, all of these diseases have elements of that type 2 immune cascade. And just really quickly, I want to bring us back to when we talked about those three age-affected systems: the barrier, the nerves, and the immune system. And often I get the question, well, if these are aberrant in the skin, why aren't they aberrant elsewhere? And the answer is they have the exact same issue that we do with poor nomenclature, mixed consensus in ENT, with this concept of rhinosinusitis in older adults. They have the same issue with chronic reactive airway disease in older adults in pulmonology. And you can see how some of these connected conditions are all tied together in this type 2 inflammatory cascade. If you look at the GI system, we have EOE. If you look at the upper respiratory tract, you see chronic rhinosinusitis. And if you're looking at the lungs, you're seeing asthma and COPD. So all of this is very connected, and these systems are very intimately connected. And if you ever have questions, talk to your ENT colleagues, talk to your upper GI colleagues, talk to your pulmonologists. They'll have a lot of the same questions that we do about their older adults that we have about our older adults who are itchy. So let's take our focus back to our team members, back to dermatology, and look at some of these very known type 2 inflammatory skin diseases that we see in older adults. So we already talked about CPUO, chronic pruritus of unknown origin, which combines all three of those systems, as does prurigo nodularis, where you're seeing neuroimmune dysregulation and activation of fibroblasts that leads to fibrosis. And how about bullous pemphigoid, where you're seeing strong type 2 immunity leading to leading to aberrant eosinophil activity and aberrant B cell activity, leading to the secretion of autoimmune cytokines. And then, of course, our baby, atopic dermatitis, which is our flagship type 2 disease. And at the core of all of these is a cytokine profile that we all know and love: IL-4, IL-13, IL-31, IL-5. And what happens is these cytokines, which are driving that appropriate response if there were active parasites in our skin, ultimately leads to this cascading of events that just goes in circles of damage to the barrier, sensitization, neural overactivity, and that cycles over and over and over again. And these conditions are great examples of it. And the concept that I think helped me really grow in this world was this concept of neuroimmunity. And the reason why neuroimmunity was so important was, for a long time, many of these type 2 diseases, we were looking for a singular cytokine or a singular aberrant actor, cell, cytokine, you name it. We were looking for one thing that was driving it. You know, how many times have we asked, you know, is this patient itchy because of their immune system or their nervous system? And what we're understanding more and more is it's almost always both. So what happens is that the immune system, in its aberrance, starts training the nerve. It starts to sensitize that nerve. And that nerve, when it's sensitized and overactive, starts to repropagate and recycle and influence those immune cells. So you're seeing this cascade where one is influencing the other and driving the next. And you can imagine that because these two, the nerves and the immune system, have this complex interplay, if this happens once or twice, it's not a big deal. But if you're seeing this happen over and over and over again, and we're talking about over years, and even decades, you're going to get perpetual aberrance in the activity of the immune system and the nerves. And we talked about that concept of training your nerves and neuroplasticity. So once that nerve is trained, then just like if you did bicep curls every day for decades, you're going to have pretty big biceps and you're going to be able to lift things pretty quickly and easily. That's what's happening to our nerves. And at the core of that are those cytokines, IL-4, IL-13, that produce the type 2 immune responses that ultimately sensitize the nerves and amplify the itch over years and decades. And as I've mentioned multiple times, at the core of our patients' complaints and concerns is this symptom of itch. The most common symptom that someone sees a dermatologist for over the age of 50, where there is not a single FDA-approved medication. It's pretty incredible that itch is so fundamental to our specialty, and yet I feel like we're just starting to pull the layers out of it. And so let's look at itch as it relates to these conditions. So 65%, 68% of patients with CPUO have daily itch, 71% in prurigo nodularis, 78% in bullous pemphigoid, and 86% in atopic dermatitis. Now here's the thing, I don't believe any of these stats. In reality, I think it's probably 95 to 100% in all these patients. How many times has someone with bullous pemphigoid come into your clinic and said, no, it's just the blisters, I'm not itchy at all? I mean, I would challenge to say that probably happens once in a blue moon. But we all know that itch is core to all of this, and it really is the connecting symptom and something that we really have to value. Oftentimes, as I referred to before, we get caught using only our superpower. We're using our eyes, we're using our morphologic skills. And it is so critical as we train ourselves, as we train the next generation, as we bring APPs into the fold, that we become skilled at not only using our eyes and our physical diagnostics, but also using our ears. I know that seems simple, but it's always really challenging to walk in a room when someone's itch is out of proportion to their skin disease. And in reality, those are people that we need to take a hold of. And this is a great slide to exemplify that. So let's talk really quickly about these diseases. So I want to introduce you, many of you probably aren't aware of what CPUO is, and I think it's because it's still going through its own diagnostic process, evolution. So just some high level things. Chronic pruritus may be localized, but it can also be generalized. It doesn't have to be all over the skin. It can be in certain areas. It can even move from place to place like many other type 2 diseases. It can present with some skin findings. I read a paper by Gil Josipovich when I was a medical student, and he was the first one to highlight that for me, where his algorithm of working up itch in older adults had this category that said rash. So he had the rash, no rash, but then he had a category in the middle that was non-definable rash. So it's not that CPUO patients can't have any rash, it just may not be as specific as say the morphology of PN or AD. And then of course, you'll very often see secondary skin changes. And as we know now that secondary skin changes are not related to really any singular diagnosis. We used to talk about the butterfly sign as a sign of psychogenic or self-imposed itch, and now we've sort of started to move beyond that and evolve to understand things that may contribute to the itch rather than anchoring based on where the itch is. As you would imagine, because I'm talking about this, there's a highest prevalence of CPUO in older adults. And the other thing that's really important is that itch is such a subjective term. It's important that we include things like burning, tingling, and stinging in our lexicon for when someone comes in saying they're really uncomfortable. Those are all very akin to itch as well, and you'll see that very frequently in CPUO patients. As you would imagine, CPUO patients have really impaired quality of life. I know we've hit on this many times, so I'll fly through this. They have daily itch, they have long-standing itch, they have sleep disturbances. There's so many ways that this condition can impact life every day. That's so similar to the other type 2 skin diseases. Now, something that people always ask is, hey, what is the diagnostic criteria? And oftentimes it's difficult to establish this. And I know there's a lot of pressure on us as dermatologists to walk in a room and know exactly what something is right when we walk in. That's a pressure that we often feel. And these CPUO patients are certainly not that. They require you sitting down and asking these questions. You have to ask about presenting symptoms. You want to talk about their medical history. I'm always asking about history of atopy for the patient, for their primary relatives, which for older adults, you may be asking a 90-year-old about their parents' family history, even if a parent passed away a long time ago. These are important pieces for you to understand that are critical to diagnosing this condition. And then of course, the lab evaluation is important. So you want to ask, or you want to get a CBC and a CMP with thyroid studies. That's pretty standard for this, but I will say there are so many different workups that I don't really blame anybody for broad workups in these circumstances, because there's not a true singular consensus. Skin biopsy may be warranted in certain conditions. A malignancy workup can be warranted if symptoms have been present for less than a year, or you're worried about other review of systems. There are elements to this that are not consensus. So I usually start with that CBC, a CMP, and thyroid, unless review of systems starts me elsewhere. And then of course, the diagnosis and treatment often come after you've actually treated someone. So theranostics or diagnostic therapeutics are really important in this population. We can talk about some of the treatments later, but those are elements of this condition that are core to it. You may not know what it is on that first visit, and that's okay. We all have to get comfortable being in that space. You'll probably hear a lot of similarities between these conditions, and that's why I want to bring in AD right after we talk about CPUO, because we talked about the heterogeneity of how it presents, where it presents, what the workup is, and that's something that we see in our AD patients as well. And particularly when we're looking at adult patients with AD, there are differences in how pediatric patients and adult patients present, because type 2 immunity changes as we age. And as we see there at the bottom of the slide, 1 in 4 report that they have adult onset AD that's after the age of 50. So there's clearly an immunologic profile that's changing. And I love this slide in the context of CPUO, PN, BP, because the skin lesions are just one piece of the disease, even though we make a lot of them from a clinical trial standpoint, from a morphology standpoint. But the true devastating effects of the disease is everything that's under the line, under the visible burden line. Now, not minimizing the visible burden, it's certainly significant and it certainly helps us, but we always have to remember how much of a challenge there is underneath the visible burden. Of course, there's itch. We've talked about sleep disturbances, cardiovascular risks, bone health risks, educational impairments, mental health challenges. These are true for many of our type 2 conditions, but we've seen the most substantial data in our AD patients. Of course, we've gone through many different shifts and work-throughs of how we define AD. You know, the Hennepin-Rajka criteria has so many little details here and there, and I hope we're able to develop more sophisticated diagnostics for CPUO and some of our other conditions. But as of right now, you're looking for essential features for AD of pruritus, eczema, and that chronicity, which are all very similar to what we see in our CPUO patients as well. And then, of course, you always want to carry a differential with these patients, as we know and love. And I'm going to fly through this because you all know that differential. And we'll pop into prurigo nodularis, which shares a lot of that similar chronicity and that similar quality of life impact. And one thing that I'll highlight here is that a majority of patients with prurigo nodularis present between the ages of 51 and 65. So it's almost like you're seeing a very similar population to CPUO, who are traditionally a bit older, as you see in prurigo nodularis. And I know when the prurigo nodularis studies came out, those initial clinical trials for prurigo nodularis treatments, it was pretty shocking to some of us that the population was so much older than was expected. And there was a long time where prurigo nodularis was thought of as a younger condition, but now we know it's actually part and parcel to the aging population. And of course, I know I'm being redundant here, but you see the signs and symptoms just along with those elements below the surface: sleep disturbances, absences from work, quality of life impairments. And patients describe it as disturbing, bothersome, agonizing, and intractable. So these type 2 diseases really have that indolent course, whether it's visualized or not, they all share that bottom part of the iceberg. And I think this is an important diagnostic slide here because, interestingly enough, this is the slide that's most similar to CPUO. And I really do think that CPUO and PN are almost the exact same disease, except maybe some fibroblast inactivity in CPUO and maybe a little bit of a skew of an older adult population. But long story short, you're looking at a very similar laboratory evaluation. You're looking for very similar questions as they present. You're asking those same questions about primary relatives. So very similar diagnostic workup for these patients if and when they come into your clinic. And then the last one, another one that's very near and dear to my heart because of the older adult population, is bullous pemphigoid. So of course, it carries the same type 2 footprint of chronic and relapsing, but it's perhaps the most debilitating of the group because of its ability to truly impair the barrier with blisters. One point that I do want to highlight here is that the non-bullous presentation is so critical, and it's estimated to be about 20% of presentations. And I would say that as of right now, that's probably a significant underestimation, despite the fact that that's still what we're saying. You know, there's a lot of patients with this type 2 disease that never present with blisters, despite the name of the disease. And that's so important for us to recognize because that is a hidden population, and they're often those older adults. As we mentioned before, this is an older adult population. It's the average age is 66 to 83, so very similar to our CPUO population. Obviously older than our AD population, but similar to the PN group as well. And as I've hit on so many times, the quality of life impairment, that area underneath the visible surface, is profound. There's physical burden, socioeconomic burden, treatment burden, mental health burden. These patients suffer. I think we all know that. And if you haven't seen a bullous pemphigoid patient, at some point when you will, this will be front and center. And the last thing I'll say about bullous pemphigoid is the diagnosis is a little bit perhaps easier in a blistered form, because the standard of care is to do a tissue biopsy with a DIF. But it is really important that we highlight the ELISA test here. This is a commercially available test that you can order at most labs. It's not a send out test or anything like that, like an IIF often is. So this is very easy to get, and often a great way of checking yourself if you have any diagnostic concern that these patients may need or may have bullous pemphigoid, and they're not in the blistering phase at that time. So in summary, thanks for letting me fly through this, my favorite topic to talk about. Chronic pruritus in older adults is a growing, under-recognized crisis. That truly is a crisis, not the population growth. And it's highly prevalent, it's multifactorial, it's a major challenge, but we don't shy away from challenges. We think they're fun, and we try to put the pieces of the puzzle together to ultimately help people. We know that the consensus now is there's not one thing that's driving the itch. We know that there's age-related changes in multiple systems, and that is the consensus. Those systems are the epidermis, the nerves, and the immune system. And the immune system can be split into those aging phenotypes of immunosenescence and more broadly inflammaging that contribute to this aberrant immune response. And this all can be captured under the type 2 umbrella, where you see this delicate communication between this type 2 immune cascade and the nerves that ultimately trains our body to repeat that itching behavior for these classic type 2 conditions like CPUO, AD, PN, and BP. And so it really is upon us to honor these older adult patients, to help them through these challenges, and hopefully accurately identify some of the problematic systems that are at play when they are suffering from their itch. So with that being said, I want to thank Roxanne. I want to thank Leon for highlighting this topic. I also want to thank Sanofi and Regeneron for highlighting this topic. It's a really important one. So thank you.
So thank you, Dan. I really think this was amazing, and I think we all love, and my audience love, this non-promotional slide decks. I think it brings a lot to the table. We have another polling question, Roxanne?
We sure do.
Okay, let's do that. Go ahead, Dan.
You have your final quiz. So back to that first question, which common pruritic skin disease of the elderly does type 2 inflammation play a central role? And you're going to select all that apply. I'm not going to give any hints. But even if type 2 inflammation plays a role, it's important that we highlight the central role, the main role. All right. Yes. Majority got it right. Yes, of course, sebderm does have a Th2 signal or a type 2 signal, but the main ones are CPUO, prurigo nodularis, and bullous pemphigoid. So great work, everybody. Thanks for paying attention to this.
So thank you so much again. I really want to thank Sanofi that actually did this slide deck that you were also involved, you prepared, because I really think this is elevating dermatology, elevating understanding of Th2 pathway for us, for the whole community. So now I want to get back. We have a bunch of questions, and we don't have much time, but I'm going to ask a couple of the burning questions that people had. You know, in most cultures, especially in Eastern cultures and Middle Eastern cultures, we value the elderly. They are the most valuable assets in the community. Unfortunately, sometimes that's not the case in our culture, in the Western cultures. And I see those patients sometimes in the nursing homes, they suffer through itching and they get a 1 pound jar of Vaseline or Eucerin and then go and smear that all over the place and try to get that skin moisture. But we know that the fundamental issue, it's not the dry skin. So having learned a little bit from what I heard, you mentioned those 3 important functions, right? Barrier dysfunction, neural hypersensitivity, and immunosenescence. Which one do you think plays the most important role tied to the Th2 pathway and that shift that you mentioned from Th1 to Th2 pathway? And is there a way to figure that out?
Yeah, it's such a good question. It's sort of the holy grail, and I'll just sort of unwrap the question, which is, can we prevent this? I think that's always been the question. If we had the perfect barrier for our whole lives, could we prevent this? And the answer to that is probably yes, but the asterisk to that is your barrier is there are probably intrinsic elements to all of our barrier that we can't necessarily control. So if I dipped you and I in a vat of Vaseline every day, yeah, maybe we would never get that type 2 switch, but we know that our environment is always trying to challenge our barrier. So I would say the barrier assault is probably number 1, but I still think that the immune element is probably what most directly relates to the itch, and that's a really hard interplay to be able to intervene on early.
Now, what do you do? And I saw your diagnostic test, but I'm always afraid that when somebody has pruritus unknown origin, am I missing a malignancy, right? And how do I catch that? What do you suggest?
Yeah, so it's a great question, and it's always hard. I think anytime someone comes in with chronic pruritus of unknown origin, I think it's really important that you never anchor. Even if you think it's CPUO, never anchor, even if you've seen them for 2 years. So if they're starting to develop symptoms, you always want to stay nimble. Sean Quatra did, though, publish a really important paper which found that malignancies associated with itch almost exclusively happened in people who had been itching for less than a year. So that's a really important one to me. If somebody comes in and they say, hey, I'm 10 out of 10 itchy, I'm miserable, there's minimal on their skin, that's actually the person that diagnostically I'm going to really push from a malignancy standpoint. But I will say most CPUO patients come in and they're like, they've been itching for 5 years. And for me, not that I don't worry about a malignancy in those people, but certainly the pressure is off to make sure that they've had all their age-appropriate cancer screenings.
Now, do we have any biomarkers that are useful that we can use to differentiate AD from PN or from CPUO? Is there something that we can hang on to?
Unfortunately, not really. There's, eosinophils and IgE are very loose markers of type 2 inflammation. They're not great. I actually started ordering them even though they were never, well, eosinophils on differential, but IgE was actually never recommended, is not really on the itch no rash differential. But what it actually helps me with is it tells me that there's some sort of immunologic overactivity. So it can help me. It helps me not necessarily diagnostically, but it helps me therapeutically say, okay, I'm going to go down the immune control pathway. But as of right now, there isn't one. There's a couple tests that sort of have loose use, but it's not great. We need someone to develop it.
Well, another project for you. So how about final question? It is hard to deal with elder patients, right? Their memory, their understanding, and sometimes they come with one family member with one visit, the next visit is with the daughter, the other visit is the son-in-law. So there is all these complications. And I think it takes a lot of time. And unfortunately, the return from government insurances are very minimal. So how do you handle that? What kind of foundation or infrastructure that you have in your clinic?
Yeah, it's a great question. I love talking about this because I think this is a practical question, and we can't just keep sweeping it under the rug. And we're all busy. It's like every dermatologist is seeing a ton of patients, and that's the reality. And so there's a couple things that I really think are important. So number one is don't try to solve everything on the first visit. You know, even if they're telling you this really long story, it's okay to send someone with triamcinolone away on the first visit. What's not okay is say, hey, here's your topical, good luck, and I'll see you in 6 months. So what I do is I do short follow-ups. I'll do end of day appointments so that I can communicate more. And then usually what I'll try to do is I do one formidable long appointment with these patients. And what I do there is called therapeutic equity, which means that if I can spend a little bit of extra time with you or your family on one occasion, that's going to help me for the next 10 times that I see you. So try, maybe not on the first time, but on the second time, to sit down, explain how you're working up the itch, call the power of attorney, talk to all the family members that need to be involved, write everything down, do all these little tricks and things that can help in these cases where someone is in that more disabled category or they need a lot more help. And then it makes it easier from that point forward. So just to recap, close follow-ups, don't try to solve anything, be patient with yourself, and then have one visit or phone call where you really build that therapeutic equity that you can pull on later when you do need a 5 or 10-minute appointment with that patient and their family.
So if you don't mind, I'm gonna steal that term, therapeutic equity, and I'll give you the credit, but I love it. That is really a good one. So I think we already past 8 p.m. Eastern time. So I thank you so much. That was so important, and that was such a good presentation. Thank you again. And I do want to thank our sponsor, Sanofi Regeneron, to create this slide deck, as well as to enable Dr. Butler to present. Thanks, everyone. And please join us tomorrow night. We have another great speaker, Dr. Neil Badia, and he's going to discuss remibrutinib, a new path forward with Rapsido. And now it's approved for urticaria, CSU, I should say. I thank you so much. Please join us tomorrow night at 7 p.m. Good night, everyone. And thank you again, Dan. Thanks.
Good night, everybody.
Good night.